This is still Chapter 5 from the 11th edition of the textbook of radiographic positioning and related anatomy. And this lecture focuses on scapula. This actual picture is from page 178. This picture right here is figure 5.6. The scapula actually has three borders to it. It has a superior border, it has a medial or vertebral border, meaning it sits close to the spine or to the vertebrae. It sits more midline. And then it has a lateral or an axillary border. If you look on this radiograph, G references the lateral or the axillary border. E represents the medial or vertebral border, and then it's not outlined on here, but actually the superior border might be what C is trying to reference right here, the superior border of the scapula. The scapula is the little wing-shaped bone on the back of a patient on the posterior aspect, very thin bone. Really odd shape to it, and if we move away from the three borders and just look at those again, the superior border, the medial or vertebral border, this would be the inferior angle of the scapula that we use for PA chest positioning. Typically, the inferior angle of the scapula correlates to T7 on a stenic patient, and then you've got lateral or axillary border here. This is the shoulder or scapulohumeral or glenohumeral joint. The axilla, meaning the armpit, that's why it's called the axillary border. And then the medial, because it's next to the vertebrae or vertebral border. This next image is looking at the scapula in an anterior view. So this is figure 5.7, and I would say that all of this anatomy is important to know. We looked at the different borders of the scapula. It also has a scapula has a neck. It has the lateral angle or the head of the scapula, the glenoid fossa where the humeral head sits to form the shoulder joint, the acromion process which connects with the acromial end of the clavicle to form the AC joint. You've got the coracoid process, which is our central ray sits 1 inch below the coracoid on shoulder images. You've got the scapular notch, the superior angle right here, and then this is the costal surface or the anterior surface. It's also referenced as the subscapular fossa. So if you're looking at this and this is an anterior view, then this is a right scapula. This would be the vertebral border, and then the right humeral head would sit in the glenoid cavity or the glenoid fossa. This next image is the posterior view, so looking at the scapula from the back or the posterior aspect. This would be the dorsal surface now versus the costal surface. This would be the medial or vertebral border. This would be the axillary border, inferior angle of the scapula. This is the infraspinous process, and this would be the supraspinous, meaning above the spine, below the spine. This is the scapular spine right here, and at the end of the scapular spine we have the acromion process. This last image, this one right here, is from figure 5.9, and this is the scapula in a lateral view. And then we also have the Y view of the scapula on a radiograph to reference. When looking at this, you can see the acromion and the coracoid process, the glenoid cavity, the spine of the scapula, the dorsal surface would be here, and then you would have the costal surface would be here. This represents the body of the scapula. This is the lateral or axillary border. Like we said, the costal surface and the inferior angle. So you'd be looking at this if you were standing looking at the patient's arm, which technically the humeral head would be in here and their arm would be there. That's how you're looking at the patient. And then this would be the front of the patient, anterior surface. This would be posterior surface. When we look at this radiograph, this is figure 5.10. Nope, 5.11 on page 179. And we look at the anatomy. We've got the acromion process is letter A. We've got the coracoid process, which is letter B. Those make up the top points of the Y, and then they come together. Letter D, this is the spine of the scapula. E is the body of the scapula. So here's how you form your Y: the acromion, the coracoid, and the body of the scapula. And then ideally the humeral head sits in the base of the Y. All right. For the scapula, there are two views to the scapula. There is an AP and a Y lateral. On these particular images, this image, the AP scapula, is on page 206 of your book. This picture right here you can see is figure 5.98 in the book. And then this radiograph right here, basically this correlates to the anatomy in the AP view. And then you can see I filled everything in for you. This is the acromion process. You've got the scapular neck. C represents the suprascapular notch. D represents the superior angle. E is the medial or vertebral border. F is the inferior angle. G is the lateral or axillary border. And then H is the glenoid cavity or the glenoid fossa. Okay, and this is how the patient is actually positioned for an AP scapula, which we will look at on page 206 in just one moment. The lateral scapula, this is the anatomy that we just looked at for what forms the Y, and this is a Y view on this particular patient, and this correlates to page 207 when we look at the lateral scapula. Going back to an AP scapula on 206, you can do this either with the patient standing erect, as in the top picture, or they can be recumbent and supine, like in the lower picture. You're at a 40-inch SID, and your IR is collimated to a 10 by 12 portrait. Now, this particular image you do have to use orthostatic breathing with, which means you're using a low MA and a long exposure time, at least 3 seconds, but ideally 4 to 5 seconds is preferred. So AP scapula, you're using a breathing technique, and you're using about 80 kVp at 5 Mass to accomplish that. The patient, ideally, if they stand, it's easier on you and probably more comfortable on them, because if you injured your scapula in the way it sits posterior, I would think lying supine on that would be extremely painful. Okay. The patient would stand in the erect position, ideally with their posterior surface in contact with the IR. And then basically what you would do is abduct the arm 90 degrees and supinate the hand. When they abduct the arm, it pulls the scapula out laterally and clears more of the thoracic structures. When they place their hand supinated on their forehead, like she has in this picture right here, or if they were lying down and they place it like that, it just pulls the scapula lateral, freer from the thoracic structure so that it's more easily visible. We said 80 kVp at 5 Mass using a breathing technique, and that can also be referred to as orthostatic breathing. So low MA, long exposure time to equal 5 Mass, and that would blur out the lungs and the ribs. This is the same technique we talked about using on a transthoracic lateral humerus. The central ray for an AP scapula is centered to mid-scapula, which is 2 inches below the coracoid and 2 inches medial from the lateral border of the patient. So before, when we talked about shoulder, we said the central ray is 1 inch below the coracoid, which was found 2 inches below mid-clavicle. So to be 2 inches below the coracoid, you could go 3 inches below mid-clavicle to achieve that. When you do that successfully, your image would appear like this, which is figure 5.100 on page 206. So the evaluation criteria on this particular image, again, 5.100 on page 206, you need to demonstrate the entire scapula. You can see here, it starts up here. We've got medial or vertebral border, inferior angle, lateral or axillary border, glenoid cavity, or glenoid fossa. The lateral border of the scapula should be free of the ribs and the lung, which here's the lateral border right here. And the exposure factors are actually ideal, and we would have used 80 kVp at 5 mass. Remember, this is done with orthostatic breathing or breathing technique, which is a low MA and a long exposure time of at least minimum of 3 seconds, ideally 4 to 5 seconds. Okay. Now, when we talk about the lateral scapula, that is actually on page 207, and there are 2 different ways that you can do the lateral scapula. You could do one particular view where you're looking at the body of the scapula, and then the other way that you can do it is when you want to demonstrate the acromion and the coracoid process. So this is figure 5.102 on 207, and this is 5.103. Both of these are done to look at the body of the scapula. So the patient is facing the board. They reach across their front of their chest and they grab the opposite shoulder. And what that does is pulls the body away, the body of the scapula, away from the thoracic cavity. You would place the central ray to the mid-vertebral border, which is about 2 inches down from the top of the shoulder and 2 inches in from the lateral border. You would use 80 at 7.5, just like we did for the Y lateral of the shoulder. And you can see that when you bring that arm across and hold the opposite shoulder, it actually pulls the body of the scapula free from superimposition, and you can visualize that and the radiologist can read that. Okay. You can see the humeral head up here. You can still make out the Y, but this demonstrates the body of the scapula. The other way that you could position the hand and the arm is to demonstrate the acromion and the coracoid process. When you're doing that, basically you are bringing the arm, it doesn't show it well, but this arm is coming behind the patient and she would be laying the back of her hand against the small of her back. Okay, so she would drop her affected arm, flex her elbow, and place it behind her lower back with the arm abducted. And that's going to demonstrate the acromion and the coracoid process. So this is figure 5.104 on page 207, and this is figure 5.105. Central ray is the same, 2 inches from the top of the shoulder and 2 from the lateral border. And again, your technique is 80 kVp at 7.5 mass. Both of these laterals and the AP are done in a 10 by 12 portrait. You're suspending respiration for this particular image. And notice when you bring the arm back behind her like that, this demonstrates the acromion process and the coracoid process. So if you're, depending on where the injury is, this would be an alternative. They're both considered Y laterals. One just demonstrates the body of the scapula better. This one demonstrates the coracoid and the acromion process. Okay. The next image, we have a lateral recumbent scapula. So this is on page 208, and this is figure 5.106. Now, because there is such an increase in OID, this results in significant magnification. Ideally with this, you would have the patient supine, you'd bring their affected arm across their chest, and then you would place the central ray to the mid-scapula lateral border. So the mid-scapular lateral border here, notice they're palpating right here, and what they're trying to palpate is the AC joint articulation in the superior border of the scapula. And they're rotating the patient up until an imaginary line between those 2 points would be perpendicular to the IR. Central ray, you're at 40 inches to table bucky, perpendicular to the mid-scapular lateral border. But like we said, this, because of that increase in OID, it results in significant magnification of this image. This is the body of the scapula in profile. Now, this image is similar to 5.107, but that does say underneath that it's an erect lateral scapula for the body. So it would look similar to this on the table, except this would be all significantly magnified because of the amount of OID that was there. Okay, so scapula is an AP and a Y lateral. There are options on the Y lateral depending on the anatomy that is preferred to be demonstrated based on the injury. The AP scapula is done with orthostatic breathing. That way it blurs the lungs and the ribs. And ideally for the patient, this is done erect, which takes the pressure off of the patient, meaning that they're not lying on their back or lying on the scapula. So that would provide more comfort for the patient as well. Make sure you review all the anatomy for the scapula and any of the positioning. If you have any questions or there's anything that was confusing, please make sure to make note of that and bring it to class, and we can discuss it and ideally clear up any confusion you might have. This is the last lecture from Chapter 5 of the 11th edition of the textbook of radiographic positioning and anatomy, related anatomy. I hope you guys have a great night, and I will see you soon.